To initiate the discussion, now I would like to invite all the panelists. For shortage of time, probably I request all the panelists to make a comment for 3 minutes, under 3 minutes, so that we can accommodate all the panelists' comments. Later on, there are many questions in the chat box, so that will be posed after the panelist discussion. Now I request Dr. Suhasini Karinam to make a comment on the assessment of 2D Doppler assessment of mitral stenosis. Dr. Suhasini.
Thank you very much. Congratulations to all the speakers. They have touched extensively on all the aspects of the transesophageal echo pertaining to mitral valve. I really enjoyed the presentation. Thank you very much for your commitment in providing us with the knowledge. As we know, the development of the transesophageal echo, especially the 3D TEE, is very much due to the surgical intervention that is happening on and evolving around the mitral valve. TEE has allowed us to not only replace the mitral valve, but also to repair the mitral valve for all its functional failure, either type 1, type 2, or type 3, whereby the comprehensive evaluation of the mitral valve is extremely important. Transesophageal echo has served us as a quality control for our cardiac surgical outcome, especially in the mitral valve intervention. Regardless of the complexity of the TE assessment that has been demonstrated by all the 4 speakers, to perform and to obtain all the information required for the surgical or the transcatheter intervention, we should not forget that the most important aspect in either the lab or the operating theater is communication. We as the cardiac anesthesiologists obtain all those information, and we must be able to communicate across with the interventionalists or the surgeons so that they can make a very important surgical decision making. Thank you very much. That's all.
Thank you, Dr. Suhasini, for nice comments. Now I request Dr. Vishwas Malik to make comments on the assessment of mitral regurgitation. Dr. Vishwas.
Yes, sir. So there's most of the time the mitral regurgitation, especially in Indian settings, it is the combination of mitral stenosis and mitral regurgitation. So the combination of the lesion needs to be assessed. And also, the surgeon wants to know the feasibility of the repair. So the feasibility of the repair is a must, and the surgical, what are the surgical options? They should be usually part of the assessment of the mitral valve repair. So in addition to that, whenever the mitral regurgitation is there, so it is important to assess the ventricular function, especially in the setting of restrictive cardiomyopathy. The mitral regurgitation repair that doesn't have a very good results. So in addition to mitral valve regurgitation, the assessment of the LV function is a must and should be part of the echo evaluation. So the strain is going to be part of that evaluation, because when the LV function might not be by ejection fraction, it might be fallacious. The strain might be helpful in such cases. Thank you, Dr. Venkateshwar.
Making comments on the current usage of 3D TEE for mitral valve assessment. Dr. Prabhakar.
Hello. Hello, good evening. I thank Dr. Muralidhar for excellent conducting of this conference. Dr. Norman has described in detail about the 3D views and the advantages and disadvantages. So what are the main advantages is we can see from the both LA side and LV side of the mitral valve, and the correction is much better analyzed. So as Vishwas was also telling, the LV function assessment is also very important for assessing the mitral regurgitation or mitral stenosis. Then in Indian context, we see most of mitral stenosis we see the commissural fusion or calcification from tip to the distinct commissure or from the vice versa is better with 3D TEV. So as Dr. Ender showed many of our procedures which can be easily done with the help of 3D TEV, the future is very bright for usage of 3D. Thank you. Thank you for this.
Thank you, Dr. Prabhakar, for your pertinent comments. Now I request Dr. Sanjeevani to make comment on beating heart mitral valve surgery, the echo perspective. Dr. Sanjeevani.
Yes, it was a wonderful explanation by Dr. Jorg Ender. And as Dr. Murlidhar says, it is impossible for us to conduct such meetings without his presence. And he has updating us on this mitral valve surgery, beating heart surgery, which reminded me of beating heart mitral valve surgery many years back we used to do, that is closed mitral valvotomy. We all must have enjoyed it. And I am very grateful to him that he has updated us. And I just wanted to ask him, in valve surgery, is there a good maintenance of LV ejection fraction, because we are not doing anything to the chordae or subvalvular structure? So Dr. Ender, please explain on that. Dr. Ender?
Yes, thank you so much for your kind comments. Yeah, so with valve in valve, you will have the same LV function as before.
Yes.
So because if it's a valve in valve, it depends on the first operation. So normally now the surgeons try to preserve the primary chords in order to improve the LV function. So, and with the valve in valve implantation, you will not change that.
Yes.
Valve in ring, if you have a mitral valve repair before, the chords are already there. So for both procedures, the LV function will be the same. So will be no problem on that.
That's the great advantage, isn't it?
Yes.
Doctor, can I ask one question to Kanakarajan?
Yeah.
Huh? Dr. Kanakarajan, there is entity called as mitral annular disjuncture, which is coming up in a very big way in the cardiology group. And there is a hidden volume of blood which is trapped behind the PML and annulus. And patient, why this is important? Because there is a sudden cardiac death in such patients in mitral valve prolapse. So can you just enlighten on this? Or maybe Dr. Mahala, if he from the cardiology group. Mitral annular disjunction is a very important cause for death in mitral valve prolapse. And it's quite common, especially in women in young age group. Sudden cardiac death may be there. Dr. Mahala is there, he can.
Yeah. You are absolutely right. In mitral valve prolapse, there are bad prognostic markers in addition to mitral regurgitation. One is the thickness of the leaflet. If the leaflet is thickened more than 5 millimeters, the chances of sudden death is very high. And all of us has experienced when there is a prolapse of the posterior mitral leaflet, you check with the mitral regurgitation in color. You will find the color is only confined to the leaflet folding. It is not going into the left atrium. So there the problem arises that we underestimate this regurgitation, which is very mild, without realizing there is a disjuncture in that particular area. And how to assess the severity of that MR, because many times I have experienced this and we underestimate that parameter. But in this context, I'll say we consider the symptomatology of the patient, and even one of the parameters is BNP. If the BNP is elevated and this MR is confined to the prolapse area, it should be given due attention. So this is a new area where we have to find out certain parameters to assess. Even the color wise is looking grade 1 or grade 2 MR. that these patients can have sudden death in addition to the thickness of the leaflets.
Do you think MRI would help in this area?
Yes, MRI will help definitely. It can assess that area of regurgitation and the volume which is confined to the folded leaflets. Yes.
And one more thing which was not discussed and is important is diastolic MR.
Yes.
If you can.
I'll say that, okay, I'll pass this question to Naman. Well, Naman has to discuss on this. Naman, can you elaborate a little bit of diastolic MR?
Hey, first of all, thank you very much for inviting me again in this session, because now I'm live. Up till now I was recorded. Thanks, Dr. Muralidhar, and nice to see all the great faculty as a moderator and panelist. Actually, first of all, like as Madam says about the disjunction, it is a very complicated thing because it is usually occurs in the like degenerative wall disease. It is a separation of annulus from the atrial wall, actually.
Yes.
So there is a separation of annulus totally against from the mitral wall, actually, from the atrial wall. So what happens? The blood passes from behind the prolapsed mitral leaflet. So that passes missed in transesophageal echocardiography. Sometimes it is unable to find out exactly from where it is leaking, actually, and that is common in the only degenerative wall, and because of the fibrosis, it is detached. So again, the mitral valve replacement is the only solution. It is difficult to do the mitral valve repair in this case. And about the diastolic MR, yes, ma'am, definitely diastolic MR is an important issue, particularly in high LVDP. And HOCM, we see this diastolic MR a lot. That particularly when the and diastolic, because of the high LVDP MR that is coming out, and it can be nicely seen on the Doppler assessment. Basically, Doppler assessment plays an important role in diagnosing. So basically, this is apart from the systolic MR of Carpentier's thing, diastolic MR is totally a separate entity. That is LV pathology. It is not a mitral leaflet pathology. It is LV pathology which leads to the diastolic MR. So the assessment criteria based on left ventricle and diastolic pressure, LA pressures, PCWP, strain imaging, and all these things favors in a and I think the medical management is the primary thing rather than the surgical intervention.
Dr. Naman, you have one more question from Dr. Jog, and 3D vena contracting area. It is already measured, recommended as a routine measurement. And what are the values in grading mitral regurgitation?
Yeah, thank you, sir. Dr. Thank you very much for the questions, and nice to see you, Anders, sir, after a long time on the online. Yes, sir. A lot of data. If I just go back in the literatures of April literature of European Heart Journal, the publications by John Gobel, I think, if I'm not forgetting the name, John Gobel has a publication in the April Journal of European Heart Journal, April review. He has nicely summarized the importance of the 3D vena contracta, particularly functional mitral regurgitation. So functional mitral regurgitation, we know that the PISA is not really giving the right way, or 2D is underestimating because of the shape of the vena contracta. So 3D has played a very important role. So yes, in functional mitral regurgitation, very good articles have published. Even if I go further back, in 2013, in ResearchGate, one of the very good article where they have given 11 studies from 2004 to 2011. Good studies has demonstrated the superiority of 3D vena contracta over the standard 2D, and they have compared with the in functional mitral regurgitation with the cardiac MRI, and then they have shown that yes, in functional mitral regurgitation it plays important role. Now the gradation important, like in 2D, they have said there is a reduction, underestimation of 2D vena contracta by 0.2 centimeters square as compared to the 3D, and that particularly they have said is a 0.4 centimeters square is the borderline to differentiate moderate to severe. That is what the things they have suggested. Even one of the articles by Hudo, he has shown that even in multiple jet, if you summarize, if you do the summation of the 3D MR jet, like if in multiple jet, then also it works works very well in the MRI when they measure by the volume status, and they have shown that it has got a very good result. So yes, functional matter regurgitations, it has really worked. But the limitations of 3D vena contracta, one is that limited temporal and limited spatial resolution, because these has little limitations. And third is how we are cropping it. Now, sir, there are two aspects of measuring 3D vena contracta. One is to just encircle the vena contracta, and second is by the planimetry or flexi splice or planar reconstruction, you just align the 2D view in a right format. So that is very important. Like, see, we only don't rely upon the 3D vena contracta, but we align with the multiplanar reconstruction or flexi splice exactly from where the vena, regurgitation is coming up with the 3D probe, and that gives a right idea rather than just only rely upon just encircling the perimetry of the 3D vena contracta. I think I've been able to answer you.
Thank you, Dr. Raman, for the nice explanation. There is a question from Professor Vital Kumar to Dr. Kanagarajan. What is silent MR? How you diagnose it? Dr. Kanagarajan. Dr. Kanagarajan. There's a, then I will go to another question.
I'll answer this question,
Okay.
Dr. Rao.
Yeah.
See, this is earlier when we put a stethoscope to auscultate mitral regurgitation, we hear a murmur, systolic murmur. So depending upon the severity, grade, or intensity, we diagnose mitral regurgitation. But many times, you put a stethoscope, you don't auscultate any murmur, or there may be a severe mitral regurgitation. So what are the possible causes for this? There are a few explanations for that. There is extreme rotation of the heart. When there is a barrel separated chest, the patient is on a ventilator with a lot of noise, patient in IABP, or the patients with a hypertrophic cardiomyopathy with MR. So you ausculted the ejection or LVOT ejection murmur. You don't hear the mitral regurgitation. Acute coronary syndrome, ACS, MR, you may miss. Even in the patients with the extreme level of rotation, gross rotation of the heart, you may miss this MR. So how do we go for this? We are not auscultating or clinically not finding MR. So obviously the tool is echo. We have to go as per the echo severity of the MR, and the management is as per the severity. So I think I answered that question.
Thank you. Thank you. And there is one question from Dr. Sahayani to Dr. Ender. Edge-to-edge repair and or neocard without annuloplasty have received criticism, especially from the surgical point of view. Do you think these are the either corrective or rather palliative procedures? To Dr. Ender.
Yeah, so thank you for the question. First of all, I think for the first period after edge-to-edge repair or neocord, it will be corrective. But as we know from the surgical history of the Alfieri stitch, just the Alfieri stitch without an annuloplasty ring will not ensure long-term results. So I think that is the reason why up to date, all over the world, the edge-to-edge repair is recommended for high-risk surgical people. So we don't do edge-to-edge repair in young, healthy people due to that reason. For the neocord or the harpoon device, one of the criteria is that the mitral ring is not dilated at all. So also for these two methods, the literature is really very rare, and we have some 5-year result, which are, let's say, encouraging in a way, but it's not as stable as, of course, a surgical repair with placing an annuloplasty ring. So up to now, I think it's palliative. It for sure helps the high-risk people, which would have no option at all beside these techniques. And we know very well that the life quality after edge-to-edge repair is very, very good in these kind of.
And there are a few more questions in the chat box. For want of time, we will be closing. I thank all the speakers, the panelists, and the participants to have a very vibrant discussion and excellent presentation. I thank you all. I hereby close this session. Thank you, everybody.
Thank you very much. Thank you, one and all. Thank you.
Thank you.
Thank you.
Thank
Thank you,
you.
Dr. Mahala, sir.
Thank you.
Thank you, Dr.
It was a
Mahala.
pleasure. Thank you.
Always pleasure to see you all.
Thank you very much. Thank you, Naman. Thank you.
Thank you.